But if you have any questions, there's a couple ways to get those questions to us. You can send a question via your chat interface there on your GoToTrainer control panel. There is also a raised hands feature on that same control panel. And at that point, everyone's muted for obvious reasons. At that point, I can unmute you and you can have a conversation with me or Day or both if you want to bring that question to the entire group here. So we've got folks from all parts of the healthcare industry, and so welcome. In the news, and so real quick, I'm gonna do maybe 20-25 minutes of the presentation. I'm gonna turn it over to Day. Day will then do about maybe 20 minutes or so. We're gonna try and keep this thing underneath an hour so you can absorb what we're trying to share with you. And then Day will turn it back over to me for some closing comments. And if I may say so myself, Day, the best part is at the end. It's all good, but the best part is at the end. So just hang in there with us. So in the news, this is unbelievable. Just recently, the Attorney General filed a lawsuit against insulin manufacturers and PBMs alleging an insulin pricing scheme. Part of that alleged scheme, I need to be careful here. Part of that alleged scheme was the renaming of rebate dollars or refunds coming back from manufacturers to PBMs that never got passed back to plan sponsors, allegedly. Centene, the parent company which owns the PBMs that provided Medicaid services to the state of Ohio, a lawsuit was brought in part for Centene charging above and beyond the true cost of PBM services, or not sharing the true cost of PBM services. The ironic part of these lawsuits, well, the first thing is we've been writing and talking about this for the better part of a decade. The second ironic part to this is exactly what we're going to talk about today. This is exactly what we're going to talk about today. And so make no mistake about it. And I'm speaking for myself here. I don't have an issue with any of these companies. When I share this information with you, it isn't to throw stones at these companies. The issue that I have are their business models, which suck. That's the issue that I have, and suck from a plan sponsor, a purchaser's, and a patient's perspective. For them, great, right? So the primary concern, not just self-funded employers, but health plans, health systems, unions, if they don't realize it, they should, is around price. That's the reason that both the state of Mississippi and the state of Ohio have filed these lawsuits. Price. And a reason that these lawsuits came about was PBM's reluctance to share information. They benefited from information failure, or in other words, information asymmetry, which means I've got all the information, you have to negotiate with me, I'm not going to share the information with you that I have, and that is going to allow me then to charge or overcharge for our services. That's the thing that has to change. No matter how you get there or who you do it in conjunction with. So the status quo is this. In those alleged lawsuits, sticking to that, using those as an example, PBMs will come in and say, you know what, we're not going to charge you an administrative fee. That's the fee that we charge to give you, your company and your employees and their dependents access to electronic claims processing. We're not going to charge you anything for that per se. But in exchange, if we're not going to charge you, or we're going to charge a reasonably, an artificially too low administrative fee, which you can see here is the lowest piece of the pie. If you buy into that, then we're then going to generate our management fee through these three buckets primarily. And the significance to you of that is you don't know how much it is. There's no accounting for that, the piece that the PBM is keeping. One way that that manifests is through spreads. A spread is not a billing error. A spread is intentional. It is the difference between what company A is billed for a set of claims and what pharmacy A is reimbursed by the PBM for those exact same set of claims. That is a spread. It's not a billing error. It's not a mistake. It's intentional. And so these lawsuits are pending as we speak between the state of Ohio and these two entities that you see on my screen. And so what the state of Ohio did was they sought more information. See, it boils down to information. They sought more information. And the director of the Ohio Department of Transformation even said, we're not saying it's too high or too low. And he's referring to this number here. It's just information we've never had before. The truth of the matter is, if Greg was here today, he would likely tell you it's not information we never had before. It's information we never thought to pursue. We're asking you to start pursuing it. As soon as the audit was done, and the $250 million just in spreads, we didn't even talk about the rebates yet. Just in spreads, they terminated the contracts. Didn't take long. You know, state governments, they don't move very fast. They moved extremely fast in this scenario. And so the concern around, and everybody loves the rebates, it's almost like it's free money. It ain't free. The intent of rebates is to help groups get to lowest net cost, right? That's the intent of rebates, to lower the cost of the prescription drugs, to lower the cost of the employer-sponsored pharmacy benefit program. And so I go back to those lawsuits, and the Mississippi AG, part of that is alleging what's called formulary steering, meaning, you know, placing brand drugs in preferred tiers, maybe sometimes over a generic that should have been there to get that drug dispensed, and then a rebate is paid. And that this kind of go. And so here's what I want to say about this slide. Very important piece. There's three primary ways in which a consultant, a broker, a PBM, or the group itself can affect change. When I say affect change, lower costs in their pharmacy benefit plan. The three ways is the network pricing, right? Eliminating spreads. The second way is eliminating the rebate spreads. In other words, minimizing or eliminating what the PBM keeps. The third way is in the benefit design. It's in the benefit design. Those are the three major pieces that drive cost within a pharmacy benefit plan, right? So I'm going to talk more about the rebates here in a bit. But the key point is that, and listen, the state of Mississippi recognizes this, is that while you may believe, or your client may believe, it's getting 90% of the rebates, 95% of the rebate, maybe you even believe you're getting 100% of the rebates. It all depends on the contract language. It depends on the contract language. But the truth is, if the state, a state in the United States of America, believes that it overpaid because it didn't get enough rebates back, why shouldn't you? Why shouldn't you? This is an example of what information success look like. Remember, information asymmetry, information failure, they're synonymous, right? Information success is the opposite of that. When we're talking about refunds, or in other words, manufacturer rebates, manufacturer revenue that goes from the manufacturer to the PBM. Manufacturers pay monies to PBMs because that's what helps get their products dispensed at the pharmacies and prescribed by doctors. That's it. And so an example of how to account for that is what's called a rebate remittance report. A PBM that claims to be transparent and pass through should be providing this level of detail to you, where when a manufacturer pays a rebate, there's a receipt. There's a receipt for it. And that receipt has the date that the product was dispensed. It's got the NDC. It's also going to have, and some of this is redacted for confidential privacy reasons. It's going to have where it was dispensed, and it's going to have the details, the costs, the day supply, etc. Some PBMs don't want you to have it because that ultimately means they're going to make less money and you're going to pay less, right? So let me turn it over to Day, and Day's going to take over and just kind of walk through with you some of the contractual terms and things that you need to be looking out for. This is powerful stuff. Don't go away. Take it over, Day.
Thanks, Tyrone. I echo Tyrone's comments about the importance of having rebate terms, the tight definition around rebate terms. As you can see in this slide, this is a typical rebate definition that you would see in a PBM-driven contract. And this obviously leaves a lot of loopholes that can be manipulated by the PBM, non-transparent PBM, at the expense of the plan sponsor. Can you turn it over to next slide, Tyrone? Thank you. So there are loopholes such as contract terms, but within that loophole, PBMs also create, rebate exclusions, such as administrative fees or health management fees or other grants that are excluded from rebates. But the thing is, based on our experience, we've seen the contract between PBM and manufacturer, and the administrative fee is not truly a flat fee. It's a percentage of the total drug price. Okay, say BWAC, right? So that means it gives more incentive for the PBMs to take out the administrative fees from the rebates and continue to, perhaps, lack of better words, siphon rebates or monies that belong to the plan sponsor through the rebate exclusion. Okay. And this slide gives you a perfect example or a perfect picture of the administrative fees that are not part of rebates that are going to the plan sponsor. Okay. Next slide. So contract terms is very, very important. I cannot stress enough the importance of having a robust and fully negotiated contract terms. Okay, so instead of having a typical definition of rebate in your contract, you should have a better contract that should specify rebate types such as manufacturer revenue, financial payment, financial incentive, credit, or any other discount that the PBM receives from the manufacturer. Okay, and nowadays, as you know, our prescription pharmacy benefit market is pretty much controlled by top 3 PBMs, and those PBMs have they're vertically integrated. They have their own insurers, they have their own pharmacies, mail order or specialty pharmacies. So nowadays you will see a lot of rebate exclusion, including the claims that are adjudicated through their own mail order pharmacy or specialty pharmacy. Plan sponsors are losing rebate money on those claims. So it is important that you vet and fully negotiate rebate terminology as part of your PBM contract. And in the same vein, the definition of brand and generic drugs are highly, highly important. Historically, the Hatch-Waxman Act set forth the structure of brand and generic. However, to this day, there's no official definition of what brand drug is, what generic drug is. So at the end of the day, it's between you as a plan sponsor and plan and the PBM. Okay. Now, brand and generic drugs tie into the pricing guarantees. So if you have a loosely defined brand or generic drugs, that means you will likely lose money on those drugs, and you wouldn't be able to execute on your cost containment strategies. Okay. So hypothetically, a non-transparent PBM can use the loosely defined generic drug definition that was in the previous slide to their advantage in various ways. So, for example, one classic driver of the drug spend of a plan sponsor is spread on the generic drugs. So PBM can pay a network pharmacy X dollar on a generic drug prescription, but charge plan sponsors significantly more than what it actually paid. Okay. So now, also vaguely defined brand and generic drug, they can also be abused by PBMs to fit their needs, meaning, pricing guarantees. So to expand on the example that we just discussed, PBM can charge brand drug pricing to the plan sponsor while paying the pharmacy generic drug reimbursement on a single source generic claim. Okay, so that actually happened that actually was alleged in the complaint filed by the Ohio and Mississippi against the Centene. Okay, next slide. So in the past few years, it is important to note that the independent pharmacy have been hit with like post-sale recruitment involving effective rates. such as generic effective rate or brand effective rate or dispensing fee effective rate, which are all jargons that are created by PBMs. Now, but the thing is, PBMs don't really specify that in their contract with the plan sponsor. So PBMs, when they using these jargons, they claw back money from the independent pharmacies, shutting them down, and also going to their pharmacies and buy them off on a cent on a dollar. At the same time, they charge plan sponsors on a different pricing. So they're in a like a better word, they're double dipping from both ends, and using their middleman position, they're able to do that. But now, as you may have seen in the past several months, there are a lot of actions that have been taken against PBMs, including but not limited to Ohio, Mississippi, Arkansas, and some other states that are actually either filing lawsuits against PBMs or investigating or passing bills, enacting laws that better regulate PBMs practices. And on the other hand, independent pharmacies, there have been more of some sort of group effort to support the bills that regulate PBMs or file lawsuit if they can to regulate and make the playing field, level the playing field with PBMs. So now, with that said, for plan sponsor, you guys have to understand the scope of PBM services provided under the contract. Okay. Generally, PBM services include pharmacy network contracting, pharmacy claims processing, mail-in specialty drug pharmacy, and formulary and rebate administration. Okay. I've seen contracts wherein the scope of PBM services was not defined, okay, and the plan sponsor did not even know whether their PBM was conducting, routine audits to maintain the integrity of the pharmacy network. So, let's assume that the plan sponsor was a Medicare Part D sponsor, then the sponsor under the federal law is obligated to monitor for any fraud and waste and abuse practices. Not only that, the PBM could have audited or investigated pharmacy claims and recouped any overpayments from the pharmacies. But the thing is, when they recoup those audit fees or overpayments, they have to turn it over to the plan sponsor. They are required to do that if the plan sponsor is Part D. However, if a plan sponsor is a self-funded employer, then whatever it says in the contract governs. Okay. So you need to have a tight control of your contract terms, and you have to understand the scope of services provided by PBMs under the contract. Okay. So going back to my comment about vertical integration, we all know that top three PBMs, they have their plan sponsor, they have their insured carriers, they have their PBM, and they have their own pharmacies, right? And they collaborate with each other. For example, Prime and ESI. Prime sold certain part of their business to ESI. Okay, so they're getting larger and larger. Okay, so with that said, obviously the conflict of interest exists. Okay, more specifically, if we go down to if we peel off the layer, United Health owns Optum. Okay, and Optum's specialty pharmacy is Briova. Cigna, Express Script, and Accredo is their specialty pharmacy. Okay. Now, one thing that I also wanted to mention is when it comes to rebate, top 3 PBMs have rebate aggregators. Okay. Optum, they have their rebate aggregator is a coalition for advanced pharmacy services. Express Script, their rebate aggregator is Ascent Health Services. Caremark, they recently launched a rebate aggregator called Zinc. And also it is also important to note that like Express Scripts rebate aggregator, Ascent Health, they're located in Switzerland. I don't know why, and I have good suspicion on why they did that.
I have to laugh at that day. I just have to laugh at that. I'm sorry.
It's this whole vertical integration and the rebate aggregators that are either owned or affiliated with those PBMs, all bulking up the total drug spending for the plan sponsor. Okay, next slide, please. Now, rebate, audit rights, audit timeframe, auditor of choice. All these are very important terms within the contract because in most plan sponsor and PBM contracts, PBMs put in contract terms that limit the plan sponsor's right to audit in some shape or form. Okay. Now, if you're lucky, you'll be able to audit once a year for the rebate, but the auditor, in most instances, has to be approved by the PBM. And in more extreme cases that I've seen, the auditor has to execute confidentiality agreement, but also the auditor is not allowed to share notes with the plan sponsor, which means that whole rebate audit is meaningless. Okay. Now, going back to my comment about rebate aggregator, I want to give you a case study about Broward County in Florida. So Broward County did a rebate audit. Okay, they did a rebate audit on OptumRx, and I think the claims were for claims submitted in 2017 calendar year. So during the rebate audit, it was the county found out that Optum only relayed or paid back the rebates that Optum received. Okay, think about this. Optum has a rebate aggregator called Coalition for Advanced Pharmacy Services. So what Optum was doing was Optum did not relay the rebates retained by the rebate aggregator to the county. Also, and this is egregious, but that rebate aggregator, Optum's rebate aggregator, contracted out its rebate administration and collection function to Express Script. And rebates retained by Express Script was not reported to the county. So this is how, and so the county was missing out on, a significant pile of rebates that were collected by Express Script and the rebate aggregator.
I, I'm sharing with you, and I'm going to get back to this, Dave, but I'm sharing with you an email that just came into us, to our team, from the Florida Department of Financial Services. This is getting real.
Mm-hmm.
This is getting real. And today's point about who can conduct the audit, PBMs tried to limit, they picked the companies that, if you allow them to in the contract, they pick the companies that they want to work with, if you understand what I'm saying. And so I think that's coming to an end. But today's point about Broward County, they're digging into this. Uh, and uh, and if we can, we're going to help them. right? If we can, we're going to help them. So I just share this with you only to say we're just not talking about stuff that we think is going to happen. We know what we're talking about here. So it's up to you what you ultimately do with the information. So let me go back to the presentation here. All right, Dave. Sorry about that.
All good. That's a real life example of what's going on. Okay, so um, to tie the loop on the rebate aggregator issue, um, the as you know, Mississippi is conducting filed a lawsuit against PBM. They're conducting investigation in the with the MCOs that are providing service to their Medicaid beneficiaries. In 2019, Mississippi's then state auditor and the attorney general launched an investigation into the Blue plans and the Blue plans pharmacy benefit manager Prime Therapeutics regarding rebates. So and what came out was the state had suspicion that there was a wrongful retention of rebates and recruitment. Okay, I don't know the result of the audit, but we do know that Mississippi has been looking into this rebate issue since 2019 and is taking action against PBMs and MCOs. Okay, so now you get you got to have broad audit rights, like I said, because PBMs are going to try to do everything to limit your right or limit your ability to conduct audits and rebate audits, because where are they going to hide money, right? Rebate has been good source of revenue for them. Okay, rebate aggregators, and when it comes to Medicaid, there are different formulas, statutory formulas. They can still, they're able to play with that because plan sponsors allow them to dictate the terms of the contract. Okay.
And the reason that they allow them to, there's probably a handful of reasons, but a lot of it is that they're just overmatched when it comes to the level of sophistication uh, that PBMs have and their clients don't. And PBMs have preyed on that. Non-fiduciary PBMs have preyed on that. And so I go back to the email, the state of Florida, today's point, the challenge that we're going to have in helping them is that we're a PBM. And so their PBMs may say, no, we're not gonna allow this PBM to audit. They hide behind proprietary information, competitive intelligence, things like that. That's hogwash. We all use the same protocols to adjudicate claims, NCPDP. The only thing that they're trying to hide is the price. That's it. They're just trying to hide the price, what we would charge and what they're charging. That's it. And so continuous monitoring, just real quick, sorry, Dave, real quick, continuous monitoring is kind of an audit. It's in lieu of an audit. It is you're monitoring the PBM's performance aggressively every month. You've got certain details that you're measuring the PBM's performance against every month. And then when you find an error, you can fix it, as opposed to waiting 18 or 24 months and you find a couple $1,000,000, but the PBM's the clause in the contract limits their exposure to 100,000. But when you find it early, you can fix it and then benefit from it in the months to come. All right.
Exactly. So continuous monitoring is extremely important. Okay. And but you need to have the ability to do so. If the PBMs take away your ability to do so, like for example, blackout dates. You can only, audit within certain, within a certain window period for within a month or within a calendar year. You need to think why they're doing that. Okay, they're not just giving you those dates to your advantage. Non-fiduciary duty PBMs, they implement policies or contract with plan sponsors to benefit themselves. Next slide, please. So, and it all starts from RFP process. Okay, you gotta have solid RFP process as a starting point. Okay, you gotta set the ground rules. Okay, clear terms to vet out PBMs that are not willing to provide transparency. Okay, PBM can purport to be transparent and try to market themselves as a pass through. However, I just gave you a real life example, Broward County, where rebates were being being deposited into the rebate aggregators pocket or other PBM's pocket. So think about that. Okay. Now you need to have, of course, plan sponsor must have knowledge. If you don't have the requisite knowledge, you gotta connect with experts in the space that know the PBM's lingo and the PBM's gamemanship. Okay, and if they propose something different than your RFP, cut them out. You gotta stick with your own plan and draft the contracts in your own language to your benefit. Okay. So you have to come up with a questionnaire to vet them out, and you need to really take control of the negotiation. Don't just delegate to or defer to brokers or consultants or contacts at the PBM. Your contacts at the PBM. Okay. At the end of the day, you are doing this for your employees or taxpayers, whoever it is. Okay. And you need to you need to have those candidates, PBM candidates, to compete with each other. Okay, and you have to base your decision on the data, not fancy interviews or presentation. Hard numbers. Okay, the cost savings that will incur if you contract with the final candidate.
And so, thank you, Dave. And in wrapping up here, we make a great team, don't we? We make a great team. And so, listen, wrapping up here, in the lawsuit in which Centene didn't admit to any wrongdoing, but it's forked over 88 million to the state of Ohio, and it set aside 1.1 billion for future potential payouts to states. That's right. It's set aside already 1.1 billion, right? Part of that, the Ohio state's claim was that Centene wasn't sharing the true cost of PBM services. It's out there for, it's out there. And so here's what the state of Ohio means by the true cost of PBM services. Everything in green at some point lands in the PBM's bank account. Everything in green lands in the PBM's bank account. The only thing that's really, the two things that are measurable in terms of cost performance towards the PBM or to the pharmacy is the admin fee and the dispensing fee, right? Those are easy. Ingredient costs, you know what those are because you get them billed, but what you don't know is what part of that the PBM is keeping. The same for manufacturer revenue. So everything in green at some point lands in the PBM's bank account. In red Cash disbursements would be when the PBM receives refunds from the manufacturer, in other words, rebates, and then passes back a share to you or your client. That's a cash disbursement. When a PBM bills you for a prescription drug and then reimburses that pharmacy for the same drug, that's a cash disbursement. Whatever is left over, people, is the PBM's management fee. The true cost of PBM services is the PBM's management fee. That's different than the ingredient cost, right? That's the cost for the drugs. What are you charging me for the service I hired you to perform? That's the cost of the PBM services. The new path says this: the house of cards is coming down, and it's coming down fast. The new path says this: PBM, you got to make money one way. At the very least, however you choose to make money, I got to know how much it is. When I say I'm talking about you. You've got to know how much it is that you're paying the PBM. And then, like the state of Ohio, you can decide whether or not it's fair. You don't really know it's fair when what they charge you is hidden in the final plan cost. It looks like you're paying for prescription drugs, but a lot of that is the PBM's take home. When we talk about earnings after cash disbursements, fancy EACD, fancy way of saying the PBM's management fee, the cost of PBM services, not the cost of the drugs, the cost of the services. In this example, Prime Therapeutics, much larger than Transparent RX, charging $57.88 per member per month. Our cost came in at the end of the year, $23.12, a difference of $37 and change, or $34 and change. That difference, $34 PMPM, is the PBM's management fee. It's safe to assume that because Prime is bigger, of course they have more buying power. They get better prices from pharmacies. They get bigger rebates than we do. But then they charge $34 per member per month, the difference between these two numbers. So when I talk about the manufacturer revenue, what part doesn't get passed back? The ingredient costs. When you're billed more than what the pharmacy was paid, that all ends up here in the form of a $34 PMPM fee to be the PBM. It's too high. It's too high. So listen, that's all we have today. We actually made good time today. Listen, we're going to be reaching out to you to see if there's an opportunity to maybe have some sort of discovery call, how we might be able to help you, both sides. But that's all the time that we have today. I'll stick around just in case any questions come in for the next couple minutes. But tell your friends, tell your colleagues, we do this once a quarter. Things change, it's fluid. We'll have new information next time. Have them join us, sit around a computer or a big screen TV, and let's have a dialogue. Appreciate the time. Thank you.